All right, so let's get started. I'm going to introduce first Mr. Mikhail James, who is a lab manager here at Johns Hopkins in the pathology department, and he'll further introduce himself um, as he goes through his presentation.
Morning, everyone, or good afternoon, I should say. Thank you guys for taking the time to come out today. We're hoping that after this session, you guys will find it very informative and very productive time to your day. So I'm just going to be really brief with you. As you know, Dr. Maynard had mentioned, my name is Mikhail James. I am the active lab manager here at Johns Hopkins Histology Lab. So the name of the lab is Oncology Tissue and Imaging Service. It's a core lab. So it's not like the main lab, but it's a subset of one of the labs here, primarily in the Department of Pathology. We are working under the Sidney Kimmel Comprehensive Cancer Center, where we do a lot of cancer research, or I should say we assist in a lot of cancer research projects for our clinicians and our investigators. So I will refer to names throughout the presentation as like a PI, which is our principal investigator, or just say investigator. So those are like our professors or our doctors who are doing research projects. So you'll hear me use that name or researcher interchangeably, but that's what I'm referring to. So I'm mainly want to talk about laboratory medicine, specifically histology. So a little bit about myself. I did my undergrad. I was primarily a bio major, pre-med major, and then I later switched the end of my junior year of college, and I switched because I was medically struggling with some migraines, and it was just, if you were a pre-med major, you know the struggle of that. So I had switched then, but I went and I got the opportunity to switch right over to public health, which was interesting because at the time, clinical public health, it's since changed now, was a great opportunity for me to utilize my biosciences, but still being able to graduate on time. So that's how I ended up in public health field, which gave me all the experiences I need to kind of see the background of healthcare. Because my overall ambition was to go into medicine. So then I got into doing my master's as public health, which focuses on different areas of expertise, working with the World Health Organization, the FDA, or different stuff like that. I got to learn about those organizations and how they help out the community and the surrounding areas. So like I was saying, I got into histology actually while working on my master's degree. And I got a job at a hospital. It was the main hospital in the city that I was living at the time where I attended college. It was a clinical anatomical pathology lab. And in that lab, I was able to come across fields of hematopathology, dermopathology, just various levels of pathology. And in that, all across the board was histology. And histology allowed me to enter those arenas of influence medically and to see what was going on behind the scenes. So oftentimes you often hear about medicine as just patient care, but histology is patient care. It's just patient care behind the scenes. Clinical work is where you're dealing with patient tissue and you're assisting in the care of the patient without ever being seen, without ever being heard. But your role as a histotechnician or histotechnologist or any form of lab technician is vital to that patient's success, vital to that patient's overall health. So it's very important that this role or any lab role or lab medical role that is attained is taken very seriously. And I was going through all this, with the ambition of continuing to go to medical school, but then COVID happened. And, COVID came into the picture and it just kind of ruined everything. So we're just going to kind of move forward here. This is where I was saying COVID came in and just ruined all my plans. But so here's a little bit of what I do. So before I became a lab manager, I was a histotech. If we could just backflip to that slide real quick. So here it shows you just generally what histology is. So histology is where you take a gross piece of tissue that is harvested, either if you're doing clinical work, doing surgery. For instance, if a patient is having a excision done or a tumor removed, it will be submitted to a pathologist for review to either confirm whether or not the individual has a type of cancer or whether or not the tumor was benign. So here in the cassettes in front of you are two rabbit eyes. So in my field of histology, we specifically do research. So we're working with animal tissue versus human tissue. So you will see how the tissue is presented to us grossly. Then we do a thing that it's fixed in formalin, which is a tissue preservative. It stops the tissue from breaking down, from dying, the cells dying, so we could retain the cell morphology. And then we process the tissue. They're embedded into cassette blocks. And then the cassette blocks are then sectioned on a special instrument called a microtome, where you see the sections of the tissue represented in the slides throughout this section of slide here. And then they're stained with our hematoxylin and eosin staining, which is our routine stain, where you could see the proteins of the cells and you could see the nucleus of the cell and get a general idea of what that tissue looks like. But we're going to talk about some non-traditional routes. We're here talking about STEM. And what STEM is just, all those sciences and those mathematics and engineering degrees that we've obtained, and then just where do you go from there? You've received your degree and you're looking to move forward, and then life happens, thing changes, and you're like, okay, so what do I do with my degree? How can I get plugged in? For instance, in my example, where I was in pursuit to medical school, I was pursuit to doing something else, and I was rerouted. Life rerouted me. COVID happened, things happened, and I was placed in this role, which I love and admire. But had I not been given this opportunity, a lot of people don't know about the ins and outs of finding areas of interest where you can utilize your STEM degrees. So this slide here is just kind of showcasing that STEM jobs are expected to grow within the next decade, right? So engineering jobs, computer jobs, mathematician jobs, doctors and stuff like that. But throughout that, one discrepancy that has been found is that there is a large underrepresentation of women in these fields, or minorities, specifically Blacks and Hispanics. And our role, minorities' role in this is sometimes we feel that, I'm not represented in those fields. For instance, if you come from a family that has migrated from another country, and you're looking to aspire in becoming a medical doctor, and you don't have that mentorship, or you don't have that camaraderie to kind of guide you or lead you down that path, you might feel like, well, how am I going to get there if I don't have access to that level of influence? Well, I'm here to tell you that you can get there. While the data may show underrepresentation, there's still a lot of minorities represented in those fields. And STEM is excelling, but in the event that, we don't get to that place, I want you guys to know that there is room still in other areas of science that you can exercise your STEM related degrees. Just moving on a little bit more, this kind of breaks down a little bit of that minority discrepancy I was talking about by race and ethnicity and disability status, even where those with either physical disabilities or mental disabilities are underutilized in these fields. And you could see by the chart here, the graph here on your left, where it gives you a breakdown of how many females are underrepresented, the male population, what that looks like, race and ethnicity, and like I said, disability. The chart to your right kind of shows just the STEM degrees or the STEM positions that are highly acquired after individuals have graduated college. But it's very interesting looking at all this data, because while I was looking into this, I did realize that while many people graduate with these degrees, there are a lot of non-STEM related career fields that are looking for individuals with STEM backgrounds. So it's not well publicized We're more typical hearing about our electrical engineering, our computer sciences, but there's a lot of fields and a lot of career areas of interest out there that employers are looking for individuals with that strong STEM background. So if for some reason you find where maybe you like the sciences, but medicine or becoming a medical doctor or pursuing a PhD is not in your interest, I do want to encourage you that there are areas out there for you to pursue. So let's talk about successes of STEM for non-MDs and PhDs. In my line of interest and where I came from, getting access to this area of medicine that I was alluding to earlier has shown me the importance of opening the doors. So histology is um, very quiet. It's a very quiet field. Not many people know about it unless you're kind of in it, right? If you're in it, you know about it. If you're not a part of it, you kind of don't know about it. But in that, me having the ability to be in this field, I have learned over the years to get plugged in, right? Find opportunities to get plugged in, find opportunities to partner um, with individuals within your area. So wherever you are now, currently in your academics or your career field or job title, find areas to get plugged in, speak to people, be open about your dreams and your aspirations because you don't know who knows who. And they could lead you to opportunities and they could give you moments of opportunities where you could get plugged in to fit into that one specific area you're interested in. And another thing is that oftentimes we don't know what we're interested in until we're given that opportunity. We don't know what we're made of until we're given that opportunity, right? Everybody wants that opportunity. So this is a great way to do that. And I've learned over the years that leveraging those opportunities for training, for skill development, for resetting your mindset for success, for building and maintaining professional mentorships, and just taking professional risk, right? Being able to have a vision for your future outside of an MD, outside of a PhD. And if that's what you're aspiring to, awesome, go for it. But within the data, it's showing us that while STEM careers are excelling, non-STEM careers are excelling even more. With the change of time over the last decade since COVID, a lot of things have become more computerized and then AI has come into the picture. So it has given us the opportunity to open a lot more doors of opportunities for individuals to come on board. So if there's anything that you guys are looking to do, definitely, go for it. Don't stop, keep going. Thank you guys.
Thank you. We're now going to shift to Dr. Lynette Vasquez, who's going to talk about a career in veterinary medicine.
Thank you, Dr. Maynard. Again, my name is Lynette. Please refer to me as Lynette. And thank you, Mr. James, for the wonderful introduction. Didn't realize we're sort of related, but sort of related feels. Dr. Maynard said I am a veterinarian who works here at the Johns Hopkins School of Medicine in the Department of Molecular and Comparative Pathobiology. The easy, short way to understand is I get to investigate why our lab animals that are used in research are either ill or if they pass away or if there is a challenge with the research model, why things aren't necessarily going according to the researcher's plan. So I get to investigate all of those cases and in that way support the lab animal veterinarians who get to see these animals day to day and they do the clinical medical treatments day in and day out if they're ill or if there's something going on with them. It's pretty much the gist of it. The way we do that is by doing post-mortem examinations. So basically it's in humans, we call it an autopsy when you do a dissection of a human after passing away. In animals, we call it a necropsy. So what we do is first the animal is presented to us. We do an external examination, then with a somewhat organized or standardized way of going through the dissection, we dissect the remains and see if there's any visible abnormalities in the organs, in the way veins and arteries are connected, in the way the bones are formed. And that's the first step. After that, we take samples of the organs, trim them, and then they get processed by a histologist. So our department has our own histologist that does our histology form for us, and she then processes the tissues and gets it on a slide, a glass slide, which I then, under the supervision of a boarded pathologist, look at and see if there's microscopic changes that explain what we're seeing in the animal, what we saw in the animal clinically, or what we saw in the necropsy grossly. And then after that, we write up a report, and then that report gets sent out not only to the clinical veterinarian who's overseeing the case, but also to the PI or the principal investigators or the researcher in charge of the lab from which the animal was submitted. So that's pretty much my day to day. So my day can vary from seeing one case to seeing 6 cases. And then in between doing the necropsies, reviewing slides or writing reports. So that's more or less what my day looks like. My father was actually in veterinary school in the Dominican Republic. He didn't get to finish, but he definitely inspired me to go into this field by telling me really cool stories about his time in vet school. So I pretty much decided I want to be a veterinarian pretty early on. How I came onto pathology, that I discovered in veterinary school. I thought I was going to be what most people think of a veterinarian, which is as someone who sees dogs and cats in a clinic. And then during my 3rd semester of veterinary school, we start the pathology section, and it was a whole new world to me. I didn't know that as a veterinarian, you could make a living just investigating why animals get ill, if there's a large mortality in a farm or things like that. You can investigate and go pretty far, do pretty cool science doing that, and then get to the bottom of what's going on. So you kind of get to play detective in a really cool way. I really like that. I also like the aspect of being behind the scenes. So I always think of myself as I'm supporting the clinician, or I'm supporting the veterinarian that's submitting the case in the diagnosis of either, does this animal have cancer? Yes, no. Did this animal have an infection? Yes, no. And more importantly to me, what kind of bacteria? Was it a fungus? Was it a protozoan? How does this organism cause disease? So I definitely got passionate about pathology in vet school. Funny enough, still was passionate about it, but wasn't 100% sure if I wanted to be a pathologist. So I did a small animal internship after vet school, and I actually worked after that in small animal practice for a year. And after 2 years of clinical practice, I decided that, you know what, pathology and behind the scenes is more my personality and the way I like to work, and I like the autonomy of it a little bit more. So that's when I decided to then apply for a 3-year residency, which I did at the University of Connecticut. So kind of where I started, I did my undergrad first. And while I was in undergrad obtaining my biological sciences degree, so very similar to Mr. James, we got a biology degree. I also worked in a immunology lab at the veterinary school where I was an undergrad. And I also spent my summers working at a veterinary clinic as an assistant. So to apply to veterinary school, they like to see that you've been exposed to different aspects of veterinary medicine. So it's really important to gain experience shadowing or volunteering at a veterinary clinic, at a shelter, in a research lab, potentially maybe working with lab animals if you have the chance, just so that they know you're a serious applicant. Then, at least for me, veterinary school was 4 years. And then after that, you can either go into veterinary practice. In my case, as a pathologist, it's recommended, or the track is to do a residency after veterinary school, which is roughly usually 3 years. And then at the end of those 3 years, you hopefully take your boards. And that basically allows you to be called a board certified anatomic pathologist, meaning you have backing from the American Veterinary College of Pathologists saying that you have met the requirements to be a anatomic pathologist. And, that's kind of how I got here. I actually finished my residency in July of last year, and then started my postdoc position here at Johns Hopkins soon after. And I guess in terms of pros and cons of my career, pros, I get to do really cool science, to be honest. I get to, investigate why animals get ill, why animals get sick. I get to work alongside clinicians. I also get to support research. So I get to I get to support science in many different ways, and that's pretty exciting. I also see some really cool diseases, some different things with the experimental models that you don't usually see. So it keeps me very intellectually stimulated. Um, the people I work with are also equally as passionate and motivated, which I love and makes coming to work a breeze and makes it fun. Some challenges I have in veterinary medicine in general. Data quick Google search will show you that according to the 2022 US Bureau of Lab Statistics, only 2% of veterinarians are Black, and less than 1% identify as Hispanic. And my family's from the Dominican Republic, so I guess I'm a double minority in the sense as a, Black Latina female in veterinary medicine. Not many people look like me, but there are a few. They're out there, and they're definitely, thus far, my experiences, they're all willing to help and chip in and kind of guide you wherever it is you want to go. Uh, my advice would be, in general, don't be afraid of taking on challenges. When you're a biology major, or a science major, it may sound like, oh my God, I have extra work to, work in a research lab. That time you're investing in that research lab is going to pay off. You're going to learn about whatever research project you're learning. You're going to learn bench skills. You're going to get to network with other scientists or other PIs that you don't know who they know or what project they're involved in that they can get you involved in and really booster your CV and get you to where you want to go next. Also, in my case, I got to take a 4-year break between undergrad and vet school, and I worked in retail. And it doesn't sound like they're related, but you know what? In retail, I really learned a lot about client communication and customer skills that really paid off when you have a, client at 3 o'clock in the morning with a really sick pet that's hysterical and you need to communicate some really bad news, and kind of having that skill definitely served me. If if anyone has any questions about veterinary medicine in general or anatomic pathology in particular, I will provide my email in the chat. You're welcome to email me directly. And thank you all for your attention, and thanks for having me.
Thank you so much, Dr. Vasquez. All right, we're going to move right along to Dr. Holder, who's going to talk about his journey to being a pediatric pulmonologist as a DO.
All right. Well, thank you all. Definitely. Can you hear me? We're good. Okay, sounds good. So Mr. James and Dr. Vasquez and Dr. Maynard, definitely a pleasure to be here. And to everyone that's here on the path to STEM career. So congratulations on everything. For myself, I'll just give a little background history. Originally from California, and I will say a lot of that exposure in California is the reason why I became a doctor. My brothers were kind of caught up in some activities that weren't too good, and myself started to see that, is the life of going into gangs and stuff like that something that I wanted, but I wanted to give back to the community in a meaningful way. So, with that, I saw my dad. He was coming from the islands, and when he came here, he was very involved in the community. So I knew I wanted to do something community focused and within healthcare. So with that, I definitely said I was gonna do something in medicine, but I didn't know which route, whether that be pediatrics or adults. But I said I'm gonna do something. So I eventually went to Hampton University, which is a historically Black college university in Hampton, Virginia. Majored in biology. I wish I didn't do that, to be honest with you. I wish I would have done something that I wanted to do, which would have been maybe like music, because I play percussion and I play trumpet, and then maybe do a pre-med option with that. But I did the biology major route, and I found myself actually struggling a little bit within the last few years. Took the MCAT and applied to a few schools, but I just really wasn't ready. So then I was like, well, I need to do something to buff up my application. Could have went either a post-bac program, I could have done research. So I decided, well, I always wanted to do kind of like a combined MD PhD program. So I just decided to do research. Was able to join with the group, publish several papers, and then I decided to go ahead and get my master's at Georgetown to kind of just buff up my application a little bit more. And that really did work in my favor. I had an opportunity to go straight to med school, but someone was like, look, why don't you take a little bit more time to just figure out if you want to, go to the school of your choice rather than kind of just settling for what you want. So I got an opportunity to work at the NIH, which was pretty cool. And with that, I applied to multiple schools. And so there's two routes of becoming a physician, one being MD and DO. And in a nutshell, there's no difference, except I'll tell you a little bit of what the DO, you get some more training on how to use other techniques and tools to treat patients. So I got accepted into both MD and DO. And I decided to go to the DO route because I was like, med school is not cheap. I want to get the financial package. Let me go that route. That's going to give me the money because I didn't want to be in a lot of debt. So I went with going to a DO school, and I kid you not, I went to a deal school. I was the second class. And with that, I thought I was going to have a lot of issues. I thought I wasn't going to get a residency. I thought there could have been just a potential array of things, but it all worked out in my favor. I would say most of my best moments in my academic career was in med school. And so I was able to do research at Harvard after my first year of med school. I got a scholarship with the AMA, pretty big scholarship that again went towards my tuition and whatnot. And so did med school. And with that, it's a 4-year program. And in your third year, you're getting exposure to all the fields. And I pretty much knew I wanted to do pediatrics. I was like, I don't want to deal with adult breath. I don't want to deal with adult feet. I don't want to deal with no adult nothing. I just thought kids were just the best. And more than anything, I wanted to be on the front line of clinical care. So I wanted to prevent the diabetes, prevent the obesity, prevent the hypertension by trying to figure out what's going on with patients and more so with families and how to get them in a healthier place. So I applied for residency. Pediatrics is 3 years of residency. I would say it's going to be either a minimum of 3 years, whether that's family medicine, internal medicine, pediatrics, and some of the primary care, all the way up to like 9 years where you're doing neurosurgery residency. So I decided to do pediatrics, went back west to Vegas, and that was pretty awesome. And then I could have either stopped the 3 years and be a general pediatrician, or I could have gone and do specialty, which I decided to do. And with that, again, you're getting exposed to all the different fields of pediatrics. So that could be pediatric neurology or pulmonary or GI. And I decided to do pulmonary because I just thought there's a lot of patients with asthma, and the majority of those are going to be those from like underserved communities. So I wanted to really address that as well as other things. So that brought me here to Hopkins, where I'm working as a pediatric pulmonologist, and then I'm really enjoying it. It's fun. I'm seeing patients with a variety of cases, whether that's a premature baby that has underdeveloped lungs, all the way to a patient that might have cystic fibrosis, which is a disease of the lungs where there's a lot of mucus buildup, all the way to those that just have a cough and it's a habit cough because they're nervous and they have stressors in life. So I see a variety of things. So that's kind of been just my career path. And it's been amazing. It's been really cool. Kind of going back to the DO route, DO, like I said, you get some training on how to use your hands to treat certain things. And it's going to be more like chronic things like back pain. It can do some like things like asthma. It can do other things like foot pain and other musculoskeletal issues. But to be honest with you, I don't even practice it anymore. I have a good amount of friends that are doing a variety of things as DO physicians. I have a good friend that's a head and neck surgeon, have multiple friends that are orthopedic surgeons, all the way down to people that are psychiatry and that do research. So I know there's always this question, well, should I go MD or DO? It doesn't matter. Do you want to be a doctor and do you want to just make sure you fulfill your passions and get it out into the community and make sure that the community is healthy as possible? Yeah, so it's been fun. I would say some of the pros would be more so, again, I'm on the front lines of trying to address the issues within childcare. So I think right now, a big thing is like mental health and trying to make sure family dynamic is strong as possible. From a pulmonary perspective, asthma is still just one of the more leading causes of childhood diseases. So I've been really focusing on that. I'll say the con to the job or to career would be seeing kids die. That's pretty tough because I work all the way from the NICU to the PICU, which is an ICU. And I think those are just really tough moments, seeing kids that are helpless and you just want to help them as best as possible. I would say people say that parents are tough. I don't see it as that. I think parents are just concerned and parents are being parents. And I am a new parent. My daughter just turned 1, and I'm understanding that lifestyle now where I'm like, okay, I see why I can get a little intense with my pediatrician or my daughter's pediatrician. So other than that, it's been really fun. I would say it's been a lot of years. Medicine is not what I thought it would be, but in the end, I really do enjoy what I'm doing on a daily basis. Um, I am fighting with insurance companies these days. I'm fighting with pharmaceutical, kind of situations, but I'll say some of the insurance companies, they're giving us a run for in terms of how to manage patients, and that's another tricky thing. But I think we're going to get there. I think with and hopefully with the progression of the country and how we get healthcare in the right place, we'll get there. And I'll leave my information. I think that's it for me.
Fantastic. Thank you so much, Dr. Holder. And we will move right along to our final speaker, who's going to talk about her work as a radiation therapist.
Thanks, Dr. Maynard. Thanks for having me, everybody. My name is Georgia Papardamas. I am a lead radiation therapist in the Department of Radiation Oncology and Molecular Sciences. So we can go ahead and get started. So who are we as radiation therapists? A lot of people pretty much don't know that we exist. We specifically work in the Department of Radiation Oncology. What we do is we give therapeutic doses of radiation to, we work with like a big group of multidisciplinary group with physicists, physicians, dosimetrists to treat various conditions, primarily cancer. What we don't do and what we get mistaken for a lot are x-ray techs. We don't take x-rays. We do diagnostic or treatment imaging, but we don't do diagnostic imaging, and we also don't give chemotherapy. And so how do we do it? This is the machine that we primarily use. It's called a linear accelerator. It delivers doses of different particles, protons, photons, electrons, and we use those to treat different sites. We treat pretty much everything, any part of the body, any age. Here in our department specifically, we treat anywhere from babies to adults. So as I was saying before, we work in a multidisciplinary group. So initially patients will come in, they'll see the doctor, the radiation oncologist, and they will prescribe a dose of radiation. And then we as the therapist kind of get the patients ready for treatment. So we will do what's called a simulation, scan the patient, make different immobilization for the patient to kind of keep them in that same position each day for treatment, which is really important because as radiation therapists, we really want to focus on treating exactly what we want to treat and not damaging any of the area around it or any of the tissue around it. So the treatment plans are then developed by a medical dosimetrist within our department. They work with the physician and kind of use the characteristics that the physician prescribes. They come up with a treatment plan, and the physician will then approve that. And then prior to the plan coming to us as a therapist, it will get QA'd and checked for safety and all of that by a medical physicist. And then once everything is good to go, it will come to the therapist and we will deliver the treatment. Go ahead. So how did I get here? Similarly to everybody else, I kind of had a journey where I didn't even know radiation therapy was a thing. So I did a 4-year undergrad. I was initially a chemistry major. I thought maybe I wanted to go the pre-med, pre-PA, that route. About halfway through that, I realized that chemistry is not something that I'm interested in. So I switched to a pre-health kind of kinesiology major at Temple University. I did a 4-year undergrad in there. I knew I wanted to do something healthcare related. I just didn't know what exactly. So graduated from college, got a job in an emergency department as a clinical assistant, trying to figure out what I wanted to do, what I was interested in, kind of exposing myself to a hospital setting a little bit more. Still at that point, didn't really know. And then I had a friend that was just talking about going into medical dosimetry. So I looked into that and wasn't super interested in that because I like having patient interactions. I like talking to people. I like being around patients. So from that, I kind of stumbled upon radiation oncology, and the job of a radiation therapist. I went, I shadowed, I loved it. So then I started researching, and I ended up applying to Jefferson University in Philadelphia and got into their program. So that was a 2-year program, and we can go on from there. So to become a radiation therapist, there are a ton of different routes you can take. Mine was a little bit different because I had done that 4-year undergrad in like a pre-health. So I kind of met a lot of my prereqs. So with Jefferson's program, it was a 2-year bachelor's. It was a 2-year, 2 bachelor's program. So you're able to select 2 different imaging-ish modalities. So for example, my first year, I got my degree in radiology. And then for my second modality, I chose radiation therapy. So it allowed me to get 2 bachelor's degrees in 2 years. And so I took my boards in both radiography and radiation therapy. So that was cool because I had those prereqs from before, I could just kind of go into that 2-year program. There are associate programs. There aren't really that many anymore. I know Maryland has one through CCBC. That's a 2-year program. It's all clinical and didactic. It's 2 straight years. And then there's also a lot of bachelor's programs popping up. A 4-year like dedicated bachelor's. I believe it's 2 years didactic and then 2 years in the clinic. And then there are a lot of therapists out there now that have certificates. Those are kind of being phased out at this point. I don't think any certificate programs still exist, but there are a lot of practicing therapists that have certificates and they're just as great as everybody else. So a lot of people wonder why I chose radiation oncology. There's a lot of negativity kind of associated with it because they think it's depressing, they think it's sad. Why would you want to work with cancer patients all day? And it's not. Working with cancer patients is really inspiring. You spend every day with that person for anywhere from a couple days to 8 weeks. So you get to know them, you get to build a relationship with them, you kind of help them through the struggles and the hard days, and it's really rewarding at the end. I'm not here to say that there aren't sad cases and you're not going to deal with things that are upsetting, because you certainly will. That's just kind of the nature of the game, especially treating pediatric patients. And you kind of build a relationship with these patients over time. So when they get bad news, it's hard on everybody. I also was interested in oncology early on. I had a friend that passed away from a really rare sarcoma. It's called desmoplastic small round cell tumor, which is not super common in the world. So that kind of piqued my interest. Another thing that I really enjoy about radiation oncology is that radiation therapy is that there are a ton of opportunities for growth, particularly within the department here at Johns Hopkins. It's a large research-based clinic, so there's always opportunities if you want to get involved in research. There's always opportunities to grow. The technology is constantly changing. I'm involved in a couple of research studies with animals. I treat anything from a monkey to a pig to a dog. So it's a little bit of everything. Another sell to me for radiation oncology was the schedules. You can't really complain about a Monday through Friday healthcare job. We work no holidays, no weekends, no nights. We typically work like business hours, which is great. We do take call in case of emergencies. They do come up, and so that's just a perk. So there's a lot of different ways to grow as a radiation therapist. There are a lot of different linear accelerators that I talked about, the machine that we use for treatment. This is a picture of our CyberKnife. Each clinic probably has different machines. So they're always growing, they're always expanding. There's always some sort of new technology that you can learn. Another aspect of being a radiation therapist besides the actual treatment is CT simulation. The CT simulation therapists prepare the patient for treatment. So like I was saying before, we want to keep the patient in the same position each day for treatment. So in a CT simulation, we'll kind of get that patient ready. So if we're treating their brain, we'll make a mask for them and they'll have to wear that mask each day for treatment. Or we make different cradles, immobilization, things like that to get the patient so that they can be as comfortable as possible while being able to be as still as possible. Proton therapy is a big thing. It's very up and coming. There's a lot of talk around proton therapy. So some people are very interested in it. Personally, not for me, but that's a really upcoming technology that's kind of popping up everywhere. You can go into education, you can go into management, and then there's also a subspecialty of radiation therapy called brachytherapy, which is something that I am very interested in, and I spent a lot of time working on brachytherapy. So I became a lead therapist within the department to try to develop our brachytherapy program. So what is brachytherapy? It is implanting different devices within the patient, kind of like a surgical setting. So it gets that surgical aspect, which I always thought was interesting. So we do a ton of different implants here. With gynecological, we treat a lot of gynecological cancers with brachytherapy. That top picture is an example of one of the applicators that we use very frequently. We treat with vaginal cylinders, we treat with interstitial implants. We treat a lot of GU cancers with brachytherapy. We do radioactive seeds. We do HDR prostates. And then within the gastrointestinal group, we treat a lot of intraoperative radiation therapies. So I'm really involved in kind of developing a pancreas IORT group. We go into the operating rooms when the patient or when the surgeons have kind of resected everything they want to resect, all the tumor cells, and we kind of insert an applicator that we create into the body cavity afterwards to kind of kill any microscopic disease. So that's a program that we're working on developing, which is really exciting. And then for skin, you can see that picture at the very bottom. We do a lot of creative things to treat skin cancers. We do a lot of surface therapy for squamous cell carcinomas of the skin, basal cell carcinomas of the skin, keloids. We treat a lot of keloids. So it's kind of a non-cancerous disease site that we treat. And then we can go to the next. And then that's pretty much it. A really quick overview of being a radiation therapist. I love what I do. I think that there are so many different things within this department that you could do as a radiation therapist and so many different site groups that you can treat and people that you can work with. And it's kind of an always changing field as technology goes on. So like everybody else, I will drop my email in the chat if anyone has any questions. Please feel free to reach out. Thank you to everybody for having me here. Yeah.
Awesome. Thank you so much for that wonderful presentation and for all the presentations. I know I certainly learned quite a bit. I'm going to stop the recording now.